I'm Todd Neal with MedPage Today, and I'm here at the American College of Cardiology meeting in New Orleans, and I'm sitting with Dr. Ralph Brindis of Kaiser Permanente Northern California, who is the immediate past president of the college. Thank you for sitting down with me, Dr. Brindis.
My pleasure.
And we're here to discuss the appropriate use of PCI. And to start out, what tools do clinicians have to assess the appropriateness of PCI?
You know, prior to a couple years ago, we didn't have a lot of good infrastructure tools or criteria with which to do that. I'm very proud that the American College of Cardiology a couple years ago had the foresight to create a document called the Appropriate Use Criteria for Coronary Revascularization. This document looks at 5 domains related to the criteria that us clinicians look at in terms of figuring out whether one should do an angioplasty, how the patient presents clinically, how much medical therapy they're on, the degree of coronary disease on angiogram, and also how much ischemia there is on non-invasive testing. These criteria then would determine, based on clinical scenarios, whether it's appropriate, inappropriate, or uncertain to do coronary intervention. In addition, with this program or with this document, we need to actually measure what we're doing. And now through the National Cardiovascular Data Registry, we actually have the data elements with which to assess whether the angioplasty was appropriate and actually feed this data back to clinicians and hospitals in benchmark form.
And now, earlier this morning, there was a presentation on data from the NCDR on the appropriateness of PCI. What did that study show?
Well, this study was a fascinating study, and to put it in context for our audience, you know, there's been a lot of attack on cardiologists about being wasted, doing inappropriate angioplasties and wasting various resources of the healthcare system. A lot of allegations going on in Maryland, Missouri, Pennsylvania, and I predict even more so this coming year about inappropriate angioplasty. In fact, just this past fall, the Dr. Oz show, Dr. Oz claimed that 50% of all angioplasties in the United States were inappropriate. This study, which actually looked at those 5 domains and the last 500,000 patients who had angioplasty within the NCDR Cath PCI database, found that approximately in the order of magnitude of 7 or 8% of angioplasties were inappropriate as opposed to 50%. Most of the angioplasties, of course, that are done in patients who are presenting with a STEMI or acute myocardial infarction or non-ST elevation myocardial infarction or acute coronary syndrome, almost by definition are appropriate. The area where there's a higher chance of finding inappropriate angioplasty occurs in those patients who are stable. To me, one of the most interesting aspects of the study, however, is the marked variation that was shown in the study between different hospitals in terms of the degree of appropriateness of angioplasty. In other words, there are clearly opportunities for improvement in terms of how we approach patients with angioplasty. I am very hopeful with this tool that we have, the National Cardiovascular Data Registry, and its reports that are benchmarked, that hospitals and physicians will look at their practice patterns and assess if there are opportunities to practice more judicious angioplasty.
Now, you mentioned that nearly all of the acute PCIs were appropriate. The figure for inappropriate PCIs for non-acute settings, elective settings, was 11%. How concerning is that figure?
Well, one of the things that we all have to appreciate as clinicians, payers, and patients is that the right answer for appropriateness is clearly not 100%. The appropriate use criteria are sort of a guidance tool. Clearly, the physician and in the context of that patient's care will be able to make the best assessment. What would be concerning to me, for example, however, is a physician or a hospital looked at their report and their overall inappropriateness was 2 or 3 times the rate of the rest of the nation, that would imply a practice, a pattern, a problem. Your comment, however, that certainly that there's more inappropriate angioplasty in the stable group really should let us think harder about how we're managing our patients. Are we giving medicines a proper trial, based on the COURAGE trial? Are we doing angioplasty in some patients that don't deserve it? For example, the OAT trial type of patients. Great opportunities.
And now there will be reports sent to hospitals describing their inappropriate PCIs, how they match up with the other hospitals. Is there any kind of follow-up, or are there any other measures that are going to be done to try to work on reducing the amount of inappropriate PCIs?
Well, they certainly has to be based on, the hospital itself has to make its own decisions about how it's going to utilize this and pursue such. One of the options that hospitals do have is, it turns out that the American College of Cardiology with the Society of Coronary Angiography and Intervention have produced a program called ACE, which is the Accreditation of Cardiovascular Excellence, which is a way of helping hospitals where they can we can go in and assess cath lab processes, quality, appropriateness, in a way if people would like some external help in assuring a quality work. A limitation to the study, and this is a key issue, is that the data that is based in the NCDR to determine appropriateness does not actually include film review. So there is a significant possibilities that the rate of inappropriateness could be higher if on film review we found that the interpretation of coronary lesions or severities was not truly accurate. So another way that a hospital could further improve its assessment of quality or appropriateness would also be to have a film review, such as a digital angiogram review or whatever, which also